بسم الله الرحمن الرحيم. الحلقة الرابعة في البريست disorders. Fourth episode in breast disorders series. We have mentioned before the congenital algorithm for the atrophy, the hypertrophy, aplasia and hypoplasia, polythelia and polymastia. And this is actually in the first one, which is called congenital abnormalities. When we are talking now about the infections, there are two entities in this section. So the first section is the mastitis or the abscess in the neonatal period. And this is actually very common finding in the neonates when a pediatric surgeon is experienced, and usually it starts with what's so-called the neonatal gynecomastia, and then the relatives or the parents start to see milk discharge from the nipple. And this is totally normal that we find this discharge, but they think it's pus. This is due to hyperprolactinemia, that it's transferred from the mother to her baby. The prolactin increased levels lead to gynecomastia that's temporary and increased secretions of the ducts and acini. But once you introduce Staphylococcus aureus through the nipple ducts by squeezing it, the swelling becomes infected and indurated, and pus can be expressed instead of milk. There are two conditions. First condition is it's a small abscess. That means that induration is more than fluctuation, and it's not all over the areola. This can be managed by ultrasound-guided needle aspiration, and it's better to do that as early as possible with IV antibiotics. In our practice, we usually skip these IV antibiotics and start oral antibiotics. But you should be aggressive with such condition because it may lead to affection of the breast size after that in the adolescence or in the adulthood. If there is fluctuation, sure, and it's a soft swelling, and it's a bag of pus actually, so you have to do either periareolar or radial incision, and this should be done as early as possible to allow for drainage and prevent the destruction of the breast tissue. This notice is written in prempury with probable decreased size of drained breast later on. That's to be consented, actually, to be consented to the parents on the long run. So this is concerning the neonatal mastitis, which is the most common along with the propubescent gynecomastia, are the two main common problems in pediatric age group in the breast disorders chapter. Others are nipple discharge in the infection, and it can be galactorrhea, like milky, normal in neonates due to hyperprolactinemia. So it's also like the start of the problem that happens after that towards the mastitis or the abscess. It starts with galactorrhea, and it's normal totally and others like cyst fluid, bloody discharge, pus discharge. This is due to duct ectasia, very rare, and bloody discharge also is very rare due to intraduct papilloma or irritation. And if bloody discharge in adolescents without malignant source, it's dilemma. And how do you know it's without malignant source? That happens when you make cytology for this bloody discharge and allow for ultrasonography on this area. And if we talk about this, it will be a very problematic dilemma, and it's not the depth that we need to study, but you should know only that there is something called bloody discharge. But if you get in depth in this, you can review the literature and the papers, updated papers about this topic. So when we summarize, we can summarize here that there is congenital breast abnormalities, atrophy, which has bilateral or unilateral atrophy, and hypertrophy, which may be virginal or secondary to tumor or exogenous, which may be in medications or hormones. Also aplasia and hypoplasia that can be associated with pollen or not, and also the athelia, and polythelia and polymastia that has to be removed even if it's small, because it will get larger after that in the adulthood with pregnancy. And then we talked about infections, and the most important is mastitis and also the nipple discharge. As to revise the gynecomastia, which we had revised already in the first and second episodes, benign proliferation in male breast, 70% of adolescents. The cause is imbalance between testosterone and estrogen. Classification with Neidig or Simmons, 1 to 5, subareolar to full breast. History is important, clinical picture is important, and also the examination by pinching test is important. And the testicular examination for hypogonadism or asymmetry is important too. And the treatment, if no tumors, 6-month follow-up up to, I said, 2 years. And if more than 2 years, hormonal profile should be investigated, like LH, HCG, testosterone, estradiol. These have been discussed in the first and second episodes. Prognosis is spontaneous resolving, and the psychological stress will resolve after it's resolving. Maybe in the problematic cases, the medical treatment like tamoxifen, which is anti-estrogen, and the surgical treatment maybe, but it's out of our scope. And last of all is the tumors. We talked about congenital, we talked about infections and gynecomastia. Last of all is tumors, prepubertal tumors, inflammatory tumors, and adolescence tumors. There's not much to talk about that, but mainly the fibroadenoma in the benign tumors is the most common, and it's usually from the age 15 till 20. And the malignant tumors like carcinoma and metastasis and phyllodes tumor are not that common. Other types are cyst or papilloma or hemangioma or lipoma that can occur in any other part of the body. Inflammatory mastitis, fibrosis and necrosis, unilateral also prepubertal tumors that grows at the mass, and accordingly you can deal with. Also, these topics in depth should be investigated by reviewing the literature case by case, because these are only the topics and not the details. To summarize what we know from the gynecomastia, the most important is to detect that there is neonatal gynecomastia and prepubertal gynecomastia, and the importance of the history taking and clinical picture and examination locally, and also the reassurance of the parents. Second of these important topics is the neonatal mastitis that occurs on top of Staphylococcus aureus infection of a neonatal gynecomastia or galactorrhea, and how to deal with either a small abscess or large abscess, snarl guided or incision and drainage, and the incision and drainage may be periareal or radial. And the radial, of course, has a less duct injury instance. Other congenital like bilateral atrophy or unilateral atrophy, their causes, and also the virginal hypertrophy and the secondary hypertrophy, and the history of medications and history of hormone take, also aplasia and polymastia and polythelia are important topics. That's to summarize breast disorders from Prempuri in 4 episodes. Thank you and see you again. I'll start next episode in gallbladder.